From an early age, I was fascinated by creating and teaching. Whether building a Ferris wheel out of Connects as a child, or later teaching over 100 undergraduates in a human cadaver lab at Central Michigan University, I've always found joy in hands-on learning and education. That passion led me to a career as a surgical physician assistant, where in 2012 I trained in robotic surgery and assisted in one of the first robotic cases at St. John Hospital in Detroit. I was later recruited by UPMC to help grow their robotic thoracic surgery program. Working with world-renowned robotic surgeon Dr. Inderpol Sakaria, we expanded the robotic surgery program throughout the UPMC system, including the Pittsburgh VA, where I initially worked as a contract provider. Beyond clinical practice, I focused on training the next generation of surgeons and PAs. I developed robotic surgery training models and instructional videos that are still in use today, teaching surgical residents and physician assistants fundamental skills like bedside assisting, knot tying, and esophageal anastomosis. I was then approached by Dr. Dupar, the current Assistant VP of Surgical Education and Research at the Pittsburgh VA, to help create a unique laboratory experience for participants that took part in our annual Benign Esophageal Conference in 2018. Never backing down from a good excuse to build a model, I went to work in my garage creating the first ever diaphragm suspension device, which would allow our team to simulate many abdominal surgeries, including Heller myotomy with fundoplication. This is a highly technical surgery for achalasia, where a surgeon must precisely cut the muscles of the esophagus to allow the patient to swallow. This model had to allow students and surgeons alike to learn both essential and advanced robotic surgical skills in the laboratory setting under the guidance of a qualified instructor. Our goal was to reduce surgeon learning curves in the operating room as to promote safe and more efficient surgeries to help maximize patient outcomes. In order to do this, I knew the model had to be low cost but high fidelity. It had to be portable and lightweight to easily store in our limited laboratory space. Drawing from my graduate teaching days, I realized the cost and logistical hurdles of cadaveric tissue. I researched alternative tissue options and found a company that provides pig tissue that was otherwise unusable in the food industry. I was able to get a block of tissue that included the pig's diaphragm, esophagus, and stomach at around $50 and could be used by multiple students. Unfortunately, Connects would not be quite strong enough to hold this tissue in place. So instead, I used PVC tubing and couplings to construct a frame and place that frame on a board to allow for easy cleaning and storage. My next challenge was, how do we suspend the diaphragm in place? I collaborated with my uncle-in-law, Korean War veteran and custom hot rodder Frank Dempster to develop a suspension system to hold the tissue in place. The first DSD was created, which quickly became an essential training tool in our laboratory. Fast forward to 2024, I was asked to produce a lab for over a dozen surgical residents and fellows by my current attending, Dr. Renee Levesque. The night before the lab, I learned that our pig diaphragm was missing due to a supply chain issue. Inspired by Plato's "Necessity is the mother of invention," I pivoted, repurposing synthetic tissue that we had in the lab to replicate the diaphragm and made some adjustments to the DSD frame. The DSD 2.0, now with improved first assistant working channel to enhance team-based training, was created. This unexpected challenge also led to a major cost-saving breakthrough. The original porcine block had increased in price from $50 in 2018 to over $250 in 2024. We then collected data from the lab participants. It showed that our hybrid porcine synthetic tissue model was both realistic and effective, helping trainees gain hand-on experience with Heller myotomy and door fundoplication. The course received overwhelming positive feedback. The residents earned ACGME simulation credit in a cost-effective in-house setting. This data was later shared at a major surgical conference by one of our residents. This experience reinforced my belief that a physician assistant can lead to innovation in surgical education.